Hello once again. This is your professor, Dr. Benjamin Cabrera, and we'll be continuing the lecture on the clinical therapeutics of antimicrobial. This is now the part 2 of the 3 lecture series. What is included in the part 2 of 3 of the clinical therapeutics of antimicrobial would be the beta-lactam antibiotics, and other cell wall synthesis inhibitors, the chloramphenicol, the sulfonamides, the miscellaneous antimicrobial agents, and urinary antiseptics and antimicrobacterial drugs. So it will be a lengthy one. So we'll be discussing the beta-lactam antibiotics and other cell wall synthesis inhibitors. So it means just beta-lactams will work on cell walls. So first is the beta-lactam would be your penicillin. The clinical uses for penicillin would be it's a narrow spectrum penicillinase susceptible agent, like your penicillin G is the prototype. It usually will cover your streptococci, meningo, gram-positive bacilli, and spirochetes. However, many strains of pneumococci are now resistant to penicillin. And so as most strains of your Staphylococcus aureus and even your Neisseria gonorrhea are also resistant to penicillin by the production of your beta-lactamases. But still, as of today, it is still the drug of choice for the conditions of syphilis. It has a very good activity against your enterococci, which can be enhanced by the addition of an aminoglycoside. The penicillin V is the oral form, which is usually used for oropharyngeal infections. Then we will have the very narrow spectrum penicillinase resistant drugs. So example of this would be your methicillin, which is the prototype. But methicillin is, though it is the prototype, it is rarely used because of the nephrotoxic potential. And also we have the nafcillin and oxacillin. And for these types of penicillin, these narrow spectrum penicillinase resistant drugs are primarily used for staphylococcal infections. And your methicillin-resistant staphylococci, example, it would be your Staphylococcus aureus, your methicillin-resistant Staphylococcus aureus, your methicillin-resistant Staphylococcus epidermidis are all resistant to all penicillins and multiple antimicrobial drugs. Now, the wider spectrum penicillinase susceptible drugs, we have your ampicillin and amoxicillin, the first gen, the simplest. These are, in the indication would be similar to your penicillin and with a good coverage for the enterococci, for Listeria monocytogenes, for Escherichia coli, for Proteus mirabilis, for the H. influenzae and Moraxella cataralis. And it is wise to use it in combination with inhibitors of your penicillinase like your flavonolic acids. In enterococcal and Listeria infection, ampicillin is synergistic when added with an aminoglycoside. The piperacillin and picarcillin are very good for gram-negative rods, and so like your Pseudomonas, the Enterobacter, and some Klebsiella. It works synergistically with aminoglycosides, and it is used in combination with penicillinase inhibitors such as tazobactam for piperacillin and or even clavulanic acid. Now let's now proceed to the cephalosporins. Okay, so we have first, second, third, and even fourth generation cephalosporin. So the first generation cephalosporin, the primary example would be your cefazolin, okay, which is the parenteral form, and the oral form would be your cephalexin. The first generation cephalosporins are very good for gram-positive cocci, okay, like your staph and your strep, for E. coli and Klebsiella pneumonia. It has minimal activity against gram-negative, so your first gen is more off for the gram-positive. Then the second generation exhibits less activity against gram-positive but have an extended gram-negative coverage. It covers the anaerobes like your Bacteroides fragilis, which are covered by cefotetan and cefoxitin. We have the sinus, ear, and respiratory infections caused by your H. influenzae or Moraxella cataralis, which you can be treated with the use of cefamandole, cefuroxime, and even cefaclor. So we have a lot of second generation cephalosporin mentioned, okay, in this slide. You have your cefotetan, cefoxitin, cefamandole, cefuroxime, and cefaclor. Then we have with the third generation cephalosporin. So first gen again is more of gram positive. Second gen less of gram positive but extended to gram negative. Now for the for the third generation, it has an increased activity against gram negative, resistant to other beta-lactam drugs, okay? And they can penetrate the blood-brain barrier except for cefoperazone and cefixime. Okay, so the third generation drugs are your ceftazidime, the cefoperazone, cefotaxime, cefixime, and ceftriaxone. Your ceftriaxone and cefotaxime or cefotaxime are most active cephalosporins against the penicillin-resistant pneumococci or PRSP strains. For Pseudomonas, cefoperazone and ceftazidime are mostly used. For infection with Bacillus fragilis, you can use ceftizoxime. Okay. For gonorrhea, we can use ceftriaxone and cefixime. Also, ceftriaxone is used good for typhoid fever, and so as with your cefixime. And now, cefixime is the drug of choice for UTI, and also can be used for pneumonia. Then the fourth generation cephalosporin would be your cefepime. It covers more resistant to, these drugs are more resistant to the beta-lactamases produced by your gram-negative, and like your Enterobacter, your Haemophilus, and Neisseria, and some penicillin-resistant pneumococci. It has a gram-positive activity of the first gen with wider gram-negative activity as exhibited by the third gen. Now we have it's still official, we have the fifth generation cephalosporin as exemplified by ceftobiprole, which is used for Pseudomonas, ceftaroline for the methicillin-resistant Staphylococcus, and your ceftolozane, which can be used for complicated intra-abdominal infections and complicated urinary tract infections. Other beta-lactam drugs like your aztreonam. This is a monobactam resistant to beta-lactamases. of some gram-negative rods like your Klebsiella, Pseudomonas, and Serratia, but it doesn't have any activity against gram-positive or the anaerobes, your Astrionam. And you have your carbapenems like your imipenem, doripenem, meropenem, and ertapenem. These are chemically different from penicillins but retains their beta-lactam ring structure. They have very low susceptibility to beta-lactamases. They can very effective even for the beta-lactamase producing organisms. So it has a wide activity against the gram-positive cocci, including some penicillin-resistant pneumococci, the gram-negative rods, and anaerobes, except for ertapenem. Carbapenems are active against Pseudomonas aeruginosa and Acinetobacter species, which are mostly hospital-acquired infections. So for if ever you'll be treating Pseudomonas, it would be wise to combine it with an aminoglycoside. Unfortunately, okay, the methicillin-resistant Staph aureus strains are resistant, okay, to the carbapenems. So the carbapenems are co-drug of choice for infections caused by your Enterobacter, Citrobacter, and Serratia species. For imipenem, imipenem is rapidly inactivated by renal dehydropeptidase 1. Hence, it is given with cilastatin, which is an inhibitor of this enzyme to increase the half-life and inhibit formation of nephrotoxic metabolite. Other cell wall or membrane active agents like your vancomycin. So vancomycin is a generic spectrum antibiotics which are used for methicillin-resistant staphylococci. This combined with a third-generation cephalosporin like your ceftriaxone for infections due to the PRSP, the penicillin-resistant pneumococci. And your vancomycin can be backup drug for infections with Clostridium difficile. Adverse reaction, okay, the Redman syndrome, which is due to histamine release. Then we have your bacitracin. Bacitracin, as we usually are seen or found in ointments, they interfere with the late stage in cell wall synthesis among gram-positive organisms. Because of its marked nephrotoxicity, it is of course limited to topical use. Then we have your cycloserine. The cycloserine is mostly used for anti-cancer. It is an anti-metabolite that blocks the incorporation of the D-ALA to the pentapeptide side chain of the peptidoglycan. Because of its neurotoxic effect that produces tremor, seizures, and psychosis, it is only used to treat multiple drug-resistant tuberculosis. Then we'll have the daptomycin. Okay, it's similar to vancomycin but with active against vancomycin-resistant strains. What is included in the part 2 of 3 of the clinical therapeutics of antimicrobial would be the beta-lactam antibiotics and other cell wall synthesis inhibitors, the chloramphenicol, the sulfonamides, the miscellaneous antimicrobial agents, and urinary antiseptics and antimicrobacterial drugs. So it will be a lengthy one. Now, after finishing penicillin and the cephalosporin, now we proceed to the chloramphenicol, the tetracyclines, the macrolides, clindamycin, streptogramins, and the dinazolid. Okay. Chloramphenicol, it's an old drug, and it has clinical use. Okay. Because of toxicity, it has a very few uses systemically, since it's more used as topical. It also can be used oral. Okay, It's a backup drug for severe infections by Salmonella, and can be used for pneumococcal and meningococcal meningitis in beta-lactam-sensitive patients, and is an optional treatment for rickettsial disease and infections caused by anaerobes like your Bacteroides flagellis. However, these are the toxicity or adverse effects, okay, produced by your chloramphenicol. Can have gastrointestinal disturbances with direct irritation and potential creation of superinfections like candida infection. Can have a bone marrow, okay, effect. It affects the bone marrow and causes reversible inhibition of your red cell maturation and rarely irreversible fatal aplastic anemia. Another adverse effect of your chloramphenicol would be your gray baby syndrome. Gray baby syndrome is noted as decrease in red cells, so there is anemia, the presence of cyanosis, and cardiovascular collapse. So that's why the baby becomes gray. So because of the cyanosis. So drug interaction. Okay. So it's good to note the drug interaction because chloramphenicol, once used, will inhibit hepatic metabolism, thus increasing now the elimination half-lives of three drugs: your phenytoin, tolbutamide, and warfarin. Now we go to tetracycline, and we'll be discussing the members of the tetracycline, which are the tetracycline itself, doxycycline, minocycline, and tigecycline. So for tetracyclines, the primary use of your tetracyclines is for the walking pneumonia or the mycoplasma pneumonia in adults. Those that infected with chlamydia can also be Trachomatis or pneumoniae, or rickettsia, Vibrios, and some spirochetes. Doxycycline is a good alternative to macrolides in initial treatment of your community-acquired pneumonia, especially that is caused by your mycoplasma. Other uses or secondary uses of tetracyclines would be, it is a very good alternative drug for syphilis. For respiratory infections caused by susceptible organisms, it can be used as a prophylaxis for chronic bronchitis, and also a treatment for leptospirosis, and topically it can be used for treatment of acne, and even orally. Your tigecycline is a derivative of the minocycline. It's a broad spectrum which includes organisms resistant to standard tetracyclines like your gram-positive cocci, resistant to methicillin, vancomycin, the beta-lactam is producing gram-negative, okay, bacteria, the anaerobes, chlamydia, and mycobacteria. Now let's proceed now to the macrolides. Okay. So the macrolides, we have the one created by Filipinos, okay, the erythromycin. It is very good for mycoplasma pneumoniae, for Corynebacterium diphtheriae, for Clostridium jejuni, for Chlamydia trachomatis, for Chlamydia pneumoniae, for Legionella pneumophila, for U. uraliticum, and your Bordetella pertussis. So erythromycin is also good for gram-positive cocci, but not for penicillin-resistant strep pneumonia strains. And also for beta-lactam is producing staphylococci, but not for medicine-resistant Staphylococcus aureus. Then we have your 1 daily dose of azithromycin, 1 daily dose to twice daily dose, okay, or 1 daily dose, yes. Similar spectrum activity but more active, okay, against H. influenzae, Oroxera cataralis, and Neisseria. It has a long half-life. That's why it's given as a single dose. It's effective for urogenital infections caused by your chlamydia trachomatis. And we can give a 4-day course for treatment that's been effective in community-acquired pneumonia. 4-day course means actually it's more they also can use a 3-day course. So 4-day at 500 milligrams once a day for 4 days or 5 days, or you can use it at 500 milligrams BID on day 1, then 500 milligram OD for days 2 and 3. Then we have the clarithromycin, a semi-spectrum erythromycin. It is good for the prophylaxis against the Mycobacterium avium complex, and it is a component in the regimen for the treatment of your H. pylori ulcers. Then we have a lesser known macrolide, your fidaxomicin. It's a narrow spectrum, selectively good against gram-positive aerobes and anaerobes if given orally. The systemic absorption is minimal. It is as effective as vancomycin. It's a special drug, and that's why it's a narrow spectrum for the treatment of Clostridium difficile colitis, possibly with a noted lower relapse rate. Then we have the telithromycin. So some macrolide resistant strains are susceptible, okay, for this drug. It acts by binding tightly to ribosomes and poor substrate for efflux pumps that mediate the resistance. So it is used in community-acquired pneumonia, including those of the multi-drug resistant organism. So it's not quite common using this drug. Okay. Then we have the clindamycin. Okay. So clindamycin is usually reserved for severe infections caused by anaerobes like your Bacteroides. It is a backup drug for the use for the treatment of your gram-positive, especially those with community-acquired strains of your methicillin-resistant Staphylococcus aureus. It is good for prophylaxis against endocarditis and valvular disease, which are those allergic to penicillin. This used in combination with pyrimethamine for the treatment of AIDS-related toxoplasmosis and also for pneumocystis jirovecii infection. Adverse effect would be gastrointestinal irritation, skin rashes, neutropenia, hepatic dysfunction, and superinfection like your this is the common drug that is as a causative agent for your Clostridium difficile pseudomembranous colitis along with ampicillin. Streptogramins has a longer half-life and exhibit post-antibiotic effects. So your penicillin-resistant pneumococci, MRSA, and VRSA, and resistant E. faecium are what this drug can treat. E. faecalis is intrinsically resistant to efflux of the drug. Dalinezolid, okay, is active against drug-resistant gram-positive cocci like your MRSA, PRSP, and VRE, as well as your Listeria monocytogenes and Corynebacteria. It binds to the unique site of the 23S ribosomal RNA of the 50S subunit. Linezolid has no cross-resistance with other protein synthesis inhibitors. Now we go to aminoglycosides. Okay. Your aminoglycoside, the clinical uses would be good for anaerobic gram-negative like your E. coli, Enterobacter, Klebsiella, Proteus, Providencia, Pseudomonas, and Serratia. The drugs that are these drugs would be your gentamicin, tropramycin, and amikacin. And they are also good for strains of your Haemophilus influenzae, Moraxella, Cataralis, and Shigella species. Though they are can just be alternative drugs. Okay. Most cases would be combined in combination with your beta-lactam antibiotics because immunoglycoside alone is not effective for gram-positive cocci. This was used for TB resistant, okay, to streptomycin. Then we can use amikacin. Streptomycin can be reserved as the last agent due to its ototoxicity, though it's included among the standard regimen, okay, for the treatment of far advanced tuberculosis. Neomycin and kanamycin are restricted to topical or for neomycin and kanamycin for oral use. So they are used to eliminate bowel flora. Gentamicin is available for topical and IV. Okay, your natilmycin is reserved for serious infections by organism resistant to other aminoglycosides. So there can be organisms that can be very resistant to other aminoglycosides. So you have your last resort will be your natilmycin. Then you have your spictinomycin. So that's it. Sole use for spictinomycin would be a backup drug used intramuscularly as a single dose for those with gonorrhea which are allergic to beta-lactams, even with your ceftriaxone. So no cross resistance with other drugs for gonorrhea. What is included in the part 2 of 3 of the clinical therapeutics of antimicrobial would be the beta-lactam antibiotics and other cell synthesis inhibitors, the chloramphenicol, the sulfonamides, the miscellaneous antimicrobial agents, and urinary antiseptics and antimicrobacterial drugs. So it will be a lengthy one. Then we'll go to the sulfonamides and the termetophen. Now we will be discussing the clinical use of the sulfonamides, which are very good for gram-positive and gram-negative and your chlamydia and nocardia. For simple urinary tract infections, we can use oral triple sulfur or even sulfoxazole. For ocular infection, we can use the topical sulfacetamide. For burn infection, we can use topical management using your mafenide or your silver sulfadazine is just the more common. For ulcerative colitis, rheumatoid arthritis, we can use oral sulfasalazine, and for toxoplasmosis, we have your oral sulfasalazine plus pyrimethamine, the hydrofolate reductase inhibitor plus folinic acid. Now we have your trimethoprim sulfamethoxazole, otherwise called your cotrimoxazole. It's very good for UTI then. It was then good for UTI, but due to resistance, it was abandoned now. And it is good for respiratory, ear and sinus infection caused by your H. influenzae and Moraxella catarrhalis. In the immunocompromised, those with you can treat your Aeromonas hydrophila, and it is the drug of choice for your pneumocystis pneumonia. And trimethoprim sulfamethoxazole is the drug of choice for nocardiosis. It is used for the treatment of cholera, typhoid fever, and cirrhosis. And it has an effect on your medicine-resistant Staphylococcus aureus and even your Listeria monocytogenes. Then we go to your fluoroquinolones. Your fluoroquinolones can be used for the infections of your urogenital and gastrointestinal tract infections caused by your gram-negative organisms like your gonococci, E. coli, Klebsiella pneumoniae, Campylobacter jejuni, Enterobacter, Pseudomonas aeruginosa, Salmonella, and Shigella. It is also used widely for the management of respiratory tract infections, skin and soft tissue infections, but effectiveness now is variable because of the development of resistance. Ciprofloxacin and ofloxacin are used as a single oral dose, okay, as alternatives only, okay, for ceftriaxone or cefixime in the treatment of gonorrhea. Now it is not advised to use it because of the increasing resistance to these two drugs. Here, ofloxacin eradicates Chlamydia trachomatis, but it needs a 7-day course of treatment. Your levofloxacin for most organisms associated with community-acquired pneumonia, like your Chlamydia, Mycoplasma, and Legionella. The gemifloxacin and moxifloxacin are wide spectrum of activity, which are very good for gram-positive, gram-negative, for atypical pneumonia, agents, and some anaerobic bacteria. Your gemifloxacin and moxifloxacin are used in the management of the carrier state of your meningococcal infection, tuberculosis, and in prophylactic management of the neutropenic patient. What is included in the part 2 of 3 of the clinical therapeutics of antimicrobial would be the beta-lactam antibiotics and other cell synthesis inhibitors, the chloramphenicol, the sulfonamides, the miscellaneous antimicrobial agents, and urinary antiseptics and antimicrobacterial drugs. So it will be a lengthy one. And now we go to the miscellaneous antimicrobial agents and urinary antiseptics. We have the metronidazole and tinidazole. These are the azole groups. Their action is the imidazole derivatives with activity against protozoa and bacteria. They undergo reductive bioactivation of nitro group by ferredoxin in an area parasite to form reactive cytotoxic interference with nucleic acid synthesis. It is effective orally, which are distributed and process the blood-brain barrier and achieve CSF levels similar to those in the blood, given intravenously and topical. Elimination requires hepatic metabolism. However, tinidazole has long elimination half-life, hence it is given only in one daily dosing. So clinical use would be used for Bacteroides and Clostridium. It is the drug of choice, okay, for Clostridium difficile, pseudomembranous colitis. It is used for anaerobic or mixed intra-abdominal infections and in brain abscesses. It is good for Gardnerella vaginalis and Helicobacter pylori. It is an antiprotozoal. Drug, okay, which is good for trichomoniasis, giardiasis, amoebiasis, intestinal amoebiasis, and amoebic hepatic abscesses. However, it has toxicity like GI irritation, headache, dark color of urine, leukopenia, dizziness, ataxia, and opportunistic fungal infection. Drug interaction, of course, it will give you the severe headache if you take in metronidazole, then later on with ethanol, okay, with wine or alcohol, and it may tend to potentiate the effect of anticoagulant effect of coumarin. Then we have a topical one, the mifepristone. So it's very good for Pseudomonas fluorescens, acts on gram-positive cocci, inhibits protein synthesis by binding to the isoleucine RNA synthetase. It is used topically since it is absorbed, and it is very good for impetigo contagiosa, especially those caused by staphylococci, which are medicine resistant type, even by your beta hemolytic strep and even Streptococcus pyogenes. It is used intranasally to eliminate staphylococcal toxicity. It can bring about local itching and burning sensations. Then we have the other topical antibiotics like your polymyxins. It is bactericidal against gram-negative bacteria, acting like cationic detergents, disrupting bacterial cell membranes. It binds and inactivate endotoxins. Okay? So clinical use, because of its toxicity, it is limited to topical therapy, okay, of resistant infections like your Enterobacter and Pseudomonas. Parenteral form is also available. Toxicity observed into systemic circulation can cause neurotoxicity like paresthesia, seasonal ataxia, and acute renal tubular necrosis. Bring about hematuria, proteinuria, and nitrogen retention. Then urinary antiseptics, your oral drugs rapidly excrete in the urine and act there to suppress bacteriuria. Okay? And urinary antiseptics lack systemic antibacterial effects but may be toxic. So our urinary antiseptic would be nitrofurantoin. It is very active against many urinary tract pathogens, but not for Proteus or Pseudomonas. Okay. With this drug, resistance emerges very slow. It is given a single daily dose and can prevent recurrent UTI. Adverse events would be, or effects would be GI irritation, skin rashes, pulmonary infiltrates, phototoxicity, neuropathies, and hemolysis, especially those being born with the congenital metabolic deficiency of glucose phosphate dehydrogenase. Okay. Then you have your nalidixic acid, which is a quinolone acting against gram-negative organism, but is still not effective against Proteus and Pseudomonas. Unlike nitrofurantoin, resistance emerges rapidly, excreted in the urine partly unchanged and partly on inactive glucuronide. Adverse effect would be GI irritation, glucosuria, skin rashes, phototoxicity, visual disturbances, and senescence stimulation. This antagonized by nitrofurantoin. Then we have methanamine. Methanamine are used to acidify urine, and it releases formaldehyde. It's not active again against Proteus, which usually alkalizes the urine, not used with sulfonamides due to the formation of insoluble complexes. So those are the urinary antiseptics. Then now we proceed to the last part of part 2 would be what is included in the part 2 of 3 of the clinical therapeutics of antimicrobial would be the beta-lactam antibiotics and other cell synthesis inhibitors, the chloramphenicol, the sulfonamides, the miscellaneous antimicrobial agents, and urinary antiseptics and antimicrobacterial drugs. So it will be a lengthy one. Antimicrobial drugs. So these are the drugs for tuberculosis. Okay, we have your isoniazid. It is a structural congener of pyridoxine, and it acts on the inhibition of the special fatty acid in the cell wall of the Mycobacterium tuberculosis or Mycobacteria, which is your mycolic acid. If used alone, resistance develop rapidly. So high-level resistance with deletion of your CATG gene, which encodes for catalase peroxidase that bioactivates isoniazid. Low-level resistance with deletion of your INHA gene, which codes with the target enzyme acyl carrier protein reductase. And isoniazid is bactericidal, okay, for actively growing tuberculosis. That's the reason why it is also used for the intensive phase. No? So intensive phase means it's a phase wherein you put a lot of drug, hoping to waiting, okay, because the weakest part of the bacterial cell wall is not when it is complete, but rather on the point of in the junction of the separation, or when they multiply, okay, on that, and it producing another bacilli. The junction would be the weakest point, and there the drugs can enter and can now disrupt, okay, the mycolic acid and destroy the mycobacterial cell wall. So it is well absorbed orally, penetrates and acts on the intracellular mycobacteria. That's why it's also used for the latent tuberculosis infection. Okay. And liver metabolism is by acetylation and under genetic control. So we have your fast acetylators, meaning they remove it in 60 to 90 minutes, and we have your slow acetylators, okay, the metabolism in 3 to 4 hours. Sure. For us Asians, we are fast acetylators. That's why we need more higher, okay, that's why we need higher dosage for isoniazid, while and fast accelerators may require higher dosage. Single most important drug in tuberculosis, the treatment of infection, okay, for prophylaxis, and for those who are tuberculosis skin test converters, or those with close contacts with an infectious case, isoniazid is given as the sole drug. So for toxicity, it exhibits neurotoxic effect, okay, like your peripheral neuritis, restlessness and muscle twitching, and insomnia. So that's why most of the isoniazid preparation is also coupled with pyridoxine. Okay. So whenever you have your neurotoxic effect, you can manage it with pyridoxine at 25 to 50 milligrams per day orally. Isoniazid is also hepatotoxic. It inhibits hepatic metabolism of drugs like your carbamazepine, phenytoin, and warfarin. It causes, okay, hemolysis among G6PD dehydrogenase deficient patient, and it can bring about a lupus-like syndrome. Then we have the second drug would be your rifampicin. Okay, it's a derivative of rifamycin. It also bactericidal, which acts via inhibition of your DNA-dependent RNA polymerase. Okay. The resistance is via changes in drug sensitivity of the polymerase. Resistance often develop when rifampicin is used alone. This will absorb and distributed even in the central nervous system. So this one crosses the blood-brain barrier, and it undergoes enterohepatic cycling, and this partially metabolized in the liver. So your free drug metabolized causes, okay, the orange or red-orange coloring of that can be eliminated mainly in the feces. And this one, the free drug and the metabolite, causes the discoloration of liquids from your saliva to the urine, mostly our urine. So in this case, it's wiser to prime your patients or the parents, if you have a pediatric patient, that the pee or the urine might be discolored red, so they won't be alarmed. Okay, so it's more even the tears can be reddish. Okay, so it's secondary to the free drug and metabolites of rifampicin. So it is used for can be used as drug for latent TB in INH intolerant patient or in close contact with INH resistant strains. Can be used for leprosy if given monthly, delays the emergence of resistance to dapsone. May be used with vancomycin for the infections due to MRSA and your PRSP. Also for meningococcal and staphylococcal carrier states. Toxicity, light chain proteinuria can be observed and may impair antibody response. It may bring about skin rashes, thrombocytopenia, nephritis, and liver dysfunction. This often, if less often than twice weekly, okay, it can bring about flu-like syndrome and anemia. strongly induces the liver drug metabolizing enzyme, your cytochrome P450. Okay. The rifabutin, equally effective antimicrobacterial drug, less likely to cause drug interactions. This is a preferred treatment of TB or other mycobacterial infections in cases of the acquired immune deficiency syndrome patients treated with CYP450 substrates, protease inhibitors, or your evavirans. Then we have your rifamycin, is also a rifampin derivative. It's absorbed from the GI tract. It is used for traveler's diarrhea. Then we have your ethambutol. Ethambutol inhibits arabinosyl transferase involved in the synthesis of your arabinogalactan, which is a component of the mycobacterial cell wall. Resistance is due to mutations in the EMB gene if the drug is used alone. It is absorbed well orally, distributed to most tissues, even your CNS, so it can also cross the blood-brain barrier. This largely eliminated and changed in the urine, thus dose reduction is needed in those patients that has renal challenges or renal impairment. So again, that is used for tuberculosis. Toxicity will be a dose-dependent visual disturbance. Okay. The dose toxicity visual disturbance can bring about decreased visual acuity and even the red-green color blindness. Okay, so it's very important for those who are driving. Okay, so because they might not distinguish the red and green color in the stoplight and optic neuritis. They might see it as only as brown. Most of these effects are reversible, fortunately. Other adverse effects would be headache, confusion, hyperuricemia. So you better be careful with those patients that has gouty arthritis or those who are genetically programmed to have or problems with their uric acid metabolism and peripheral neuritis. Then you have your pyrazinamide. Okay, so the mechanism still is not known. It's among the antimicrobial. This one is the bacteriostatic one. It requires metabolic conversion via your pyrazinamidase. Resistance by mutation in the gene and increased expression of the drug if toxicity. Minimal cross resistance with other anti-inhibitors. So it is well absorbed orally, penetrates most tissues and even your CNS. So it crosses the blood-brain barrier. The parent molecule and even the metabolite can be excreted in the urine. Okay. Half-life is increased in cases of either hepatic or renal failure. So this is used for TB toxicity. 40% develop gouty polyarthralgia. Okay, just like it, they can cause hyperuricemia. Can be asymptomatic. Okay, can cause myalgia, GI irritation, maculopapular rash, hepatic dysfunction, porphyria, photosensitivity reactions. Then you have your streptomycin. Okay, this is primarily in drug combinations for the treatment of life-threatening tuberculosis, like your TB meningitis, meningitis, TB, severe organ tuberculosis, or those with far advanced with cavitary type of tuberculosis. Then other alternative drug for the treatment of TB would be your amikacin. So it's an streptomycin resistant, used for streptomycin resistant or multi-drug resistant strains of tuberculosis. It's used to avoid the emergence of resistance. So always use in combination. Then you can also use your ciprofloxacin and ofloxacin. Okay, if the TB strain would be resistant to the first-line agents. This used in combination regimens with 2 or more other active agents. Then you can have your ethionamide, which is a congener of INH, but cross-resistance does not occur, can cause severe GI irritation and adverse neurologic effects. And we can have your para-aminosalicylic acid. So this is rarely used because of primary resistance is common. Other drugs of limited use because of their toxicity include capreomycin, it exhibits ototoxicity and renal dysfunction, and cycloserine, which causes peripheral neuropathy and CNS infection. So that's it. That's the last slide for the part 2 of 3 of the clinical therapeutics. And I'll be uploading also the part 3 of 3, okay, in a while. So learn well, and of course, you click like, subscribe, and please share this lecture. Thank you. What is included in the part 2 of 3 of the clinical therapeutics of antimicrobial would be the beta-lactam antibiotics and other cell wall synthesis inhibitors, the chloramphenicol, the sulfonamides, the miscellaneous antimicrobial agents, and urinary antiseptics and antimicrobacterial drugs. So it will be a lengthy one. What is included in the part 2 of 3 of the clinical therapeutics of antimicrobial would be the beta-lactam antibiotics and other cell wall synthesis inhibitors, the chloramphenicol, the sulfonamides, the miscellaneous antimicrobial agents, and urinary antiseptics and antimicrobacterial drugs. So it will be a lengthy one.